What happens when you break your ankle in a car crash? What if a doctor tells you, hey, you tore a ligament and you actually have a broken bone? What happens when you find out, right, later that it's actually a broken bone? How relieving would that be? That's my example for everybody. Is like, how relieving is it to know what's actually wrong? You know, not here's these codes. You're depressed. Are you depressed because you drink, or you drink because you're depressed? Which one is it? We don't know, but let's figure it out. The chicken or the egg?
Hey, welcome back to MasterMined. I'm your host, Mark Scrivner, and as always, I'm joined by my fabulous co-host, Jeff Skillen. Jeff, man, welcome to the show, bud.
Mark, it's always a pleasure. Today's going to be a great episode.
Yeah, this is. Man, we're lucky that the AI conference is in town because we pulled a couple really interesting people and really excited about this episode.
Yeah, I mean, the AI conference is at the Gaylord Hotel in Nashville this week, and we've got a bunch of industry VIPs in town. And we were super lucky that Cole snuck away and was willing to come in studio to come see us today. And, you know, I mean, we're going to get to know Cole, and a number of you probably already do know Cole. But before we even started rolling this episode, Cole was showing us some of the cool things that he's done in AI already. And I'm just saying that, you know what, we've got a true Renaissance guy in the studio here today.
Yeah, today we're joined by Cole Dyar. He's the executive director of Northbound Treatment Services and co-founder of Nourish Wellness. Cole, welcome to the show, man. Great to have you. Let's jump right into it.
Thanks for having me. Absolutely.
Yeah, man. Well, maybe just to kick us off, maybe you can take the audience through your journey. How'd you get into this, what was it, 15, 20 years ago?
Yeah, about 14, 15 years ago.
Okay.
Yeah, so about 14, 15 years ago, I got sober, and I grew up around education, and, when I got into the rooms, I had a friend who said, you'd be really good at this. And I said, be really good at what? She's like, well, I work for a company that, works with, youth, adolescents, and does primary mental health work with autism, multiple disorders that we go in the homes. It's called TBS, Therapeutic Behavioral Services. I said, all right, we'll give it a try. Turned out I ended up to be really good at it, and had a lot of fun, and then, moved on through that. And then, a circumstance, I ended up getting sober again, almost 11 years ago. And, if it wasn't for people like, Doug Penny, Joe Tinnervin at that time, Marion Ross, they all worked together to get me into treatment. And I didn't know those other ones. I knew Doug, and it was some kind of miracle. So I thank them every year, just to let them know, and then I ended up in San Diego, and I ended up back working in mental health, but this time I started at the very bottom of substance use and, working PHP, IOP. I was a house manager, then I was an operations manager. Then I was like, I'm going to be a counselor. So I went and got my counseling credential. Then I was a counselor. And then, for the first time in my life, I had somebody who kind of believed in me and wanted me to help them expand their brand. So we took it out to the desert in California, like Palm Desert around, Betty Ford's and the Michael's house and such things. And, I expanded the brand out there with them and kept going the whole time I was in school. It's such a long story, but, then I got a master's degree in industrial organizational psychology at the time, and then realized, man, I don't want to do this, but it's useful. So I went and got an MFT master's, entered the MFT doctoral program, and kind of from there just kept going. In the interim, I started wanting to build mental health programs. I was working in substance use, and stop me anytime if I need to. I was working in substance use, and what I started to see as a clinician and as an operator was a need. There was a lot of problems with clients coming in with just conditions we couldn't treat. And when we would try to get them somewhere safe, it was essentially the hospital, and they'd be out in 17 hours, or they'd be out in 6 hours. And then it was like, there was a couple places at the time, like, God bless, like the Mission for Michael's, and, the few people that could do it, but they were full, or, they had strict standards too, because, look, I mean, you got to do the right work, and they knew that at the time, such places, right? And there was a few other ones that are really great. And at the time, I really wanted to build, something different. I had this model with a buddy of mine Dan Parrish out in Utah, Agua Recovery. He and I and a former Hazleton person, we were developing models of like, look, there's all these issues. The primary psychiatric disorders that are driving substance use are not being treated, and these clients are coming into substance use facilities and their benefits are getting burned. What's happening is when they try to go to somewhere like the good places, there's no longer a mental health benefit, or they can't get authorization. And the majority of these types of clients, whether it be a client in psychosis who's not meeting criteria for the hospital, a client who's in a manic episode, right? Then they get them stabilized. What do you do after? What do you do after? And what do you do when they won't go to the hospital? They're smart enough. They have enough insight. They're going to tell you, like, I know all the things to say. And because the hospital trauma and the readmission rates for hospitals are so high, I started doing the data at the time because I was a doctoral student learning how to do that, And so we built a model and we thought, oh, this would be great, like a luxury crisis thing. And then the pandemic happened, And, we were trying to get funding. That was a new space for me about 7 years ago. Didn't know much about, it wasn't necessarily private equity, but that kind of world or somebody who wanted to partner. And I ended up going to working for another place in San Diego. I had met my wife, and they wanted to start their brand in another region as well. So I had a little experience, and they wanted to do some mental health crisis. And I was like, I have a model, and they had some really good, operating procedures. And we had I'm talking the contracting, like all the way down from, putting where the nursing station windows go. And man, we worked on that thing. It was just a little tiny crisis stabilization, and it was really enlightening to see, like, look, these patients had nowhere to go in between, and this was about 2022, just to kind of place the story in the timeline. And these patients had nowhere to go, and then we kind of had a place for them. And, these patients were in psychosis, like actively psychotic, but not dangerous. There was a few, exclusion criteria, and had a really great clinical director at the time who was like my partner down there, Katerina Archer. And like we did everything we could to try to fit the model well. And we did a good job, I think, and it was kind of the first time I'd seen that. I'm sure other people did it with that license in California, but I hadn't heard about it in our space much, right? And so we built that, and it was successful. And then, I had a conversation, and I was feeling creative, and I had a conversation with, I was at a barbecue actually with Jillian Christofferson from Northbound. She's a COO over there, and she's a friend of mine for many years. And she was saying like, hey, we want to build out primary psych at Northbound. And I said, great, let's have a conversation. And so I met with Paul Alexander, the CEO, and the CMO, Alexa Pellick, and the whole executive team, right? About 3 times. And then it was just kind of like it fit. We want to do this. We got a couple licenses that are, non-ops, and we want you to come in and do that. And I was like, okay. So wow. About 2023, I came in and still working on the doctoral project, right? Which ended up being like, it just worked hand in hand in tandem because it was a manual for non-clinical staff to manage patients in active psychosis. So that's what I was researching. That's what we were doing, It was a lot of fun, And I came in, and we started with one residential, and then we moved it to a nicer house. Then we got another residential, and then they're like, hey, we want to do crisis now. I said, all right, just want to do crisis. And then we got a crisis going. And then the first residential we went in with the license that was non-op, we saved it, and then we went back and did a 4th one, And it's such a good story. Like it started with me and Dr. Ross Tafik, they kind of together with Northbound's team. And from there, I think we built a staff of probably about 70, or something like that with the Northbound team, and their admissions, like people are crazy good, and, and their BD team. And, my wife's actually the creative director for the digital marketing company we used, and we built that brand with her from the bottom up. So it was kind of cool to be able to develop this whole picture, this whole beautiful place with these great people for clients who really need service that they're not getting, And even to the point where we understand, like, look, out-of-network stuff is like, yeah, we get it. You know, you're going to do another out-of-network facility. So we're trying to go in-network. Like, trying to do it the right way so the people who need help get help long-term. We get them a place to launch. You know, we got a brilliant team.
Man,
and
Cole, you're a fixer. I get a couple things. One, you care. You want to make a difference.
Try.
But two, you fix like a challenge that's in front of you or the team, you're going to fix it. And so it's very impressive. I'd love to take it back to just, you said early on, your very first stint, you were really good at it. What'd that look like? What was really good at it? What'd that look like?
Really good at when did I say
when you got into this field and you got in your first stint?
Yeah.
They saw you were really good at it. What?
It's interesting. I worked with a lot of social workers. I worked with and you know, I have that like brand based like marketing side of me from the music days, and like I love like to make things exciting, you know, and it's not my mind like, oh, this mental health treatment needs to be marketable, but it happens to be a benefit, you know?
Totally.
And so that excitement, I guess, was contagious, because what I would do is I would do these special projects with the clients. You know, I would take that extra step. And it wasn't because I wanted like this recognition. It was a friend of mine, Noelle. Her name is Noelle. She's been my friend to this day. Basically what happened was I would connect with the kids and the, you know, there were young kids and they were brother and sister combos, and we would both, you know, do coaching with them. And, you know, this is disenfranchised youth. I mean, sometimes it was like adopted kids in very wealthy families. Sometimes it was, you know, this is foster care. These are kids that have never had anyone be nice to them, you know? Never had anyone care. You know? And so when you do art projects for them, build them special stress balls, I don't think about it as like, you know, they're like, you're good at this. But for them, they were like, man, you're really good at this, you know? And it gave those, I guess that's what felt good. It's like, I guess, I didn't even realize I was doing something that, you know, they never had done for them before.
Well, you made the connection. You cared about them. And so that's awesome. Thanks for sharing.
Yeah.
So Cole, a couple big name drops there. So it's like, so shout out to Doug.
Yeah.
Shout out to Jillian.
Yeah. Good people.
Yeah. The people, as it were.
Yeah.
So when you talk about the barbecue where Jillian was like, hey, let's do this, was that the Capella barbecue?
No. This was actually at their house.
Oh, that was at their house. Oh, okay.
I'm very good at storylines, right? So I was like, and she just said that they'd want to do like actual primary psych. So
okay, got it.
Cool.
So, you know, the other thing that really comes out when you lay out your story like that is like, boy, it seems like curiosity is the name of the game. It's like, it seems like lifelong learner, lifelong student, and you're just like endlessly curious. We're just like, what about this? What about this? What about this? Yeah. Where does that come from?
My mom. Yeah, my mom's a special ed teacher, 45 years.
Wow.
Special education. She actually teaches special education at Fresno State now. Like, I mean, she's in her 70s, just still trucking, you know. And my older brother. My older brother's an artist, like always has been. You know, those curiosities of being a creative kid and not really knowing the outlets, right? Or, you know, dealing with what we dealt with as children, you know, that like, you know, mom was really like, hey, you're not going to go out there in this place. We're from Fresno, you know, so you're not going to go out there, but you can do this art project. You can do this, like, check this book out. You know, you're already reading on this level. I think, you know, I have a lot of that from her. You know, if I was to dedicate to anyone, it's from her and for him, because he was the guy when my dad was kind of like out of the house for a while. Like, my brother was parentified, you know, but he was the guy, and he still is. He's still my creative inspiration, still just genius and curious, and I want to be like him, you know? He says he wants to be like me, but I want to be like him. So, yeah.
Well, Cole, what specific problem were you trying to solve when you launched like Nourish Wellness?
Okay, so it goes back to the realities of what these patients face. And what you see is diagnosing for dollars. I mean, there's articles about that. It's not like a phrase I coined, you know? When I was doing research for my doctoral project, initially it was a lot about substance use co-occurring, you know, versus just primary psych. And what I found was like the primary psychiatric disorders that drive and fuel a lot of substance use disorders get lost in the mix, and people get so concerned with diagnosis also because it gets them authorization that they get lost in it and they forget about the etiology and the things that create the disease model, right? Mm-hmm. So even with addiction, they forget about it. It's just like, oh, they're stop, go, this, that. Look, that inside of those people are people, you know? It sounds like redundant, but it's true. It's like inside of that person is a person. So what do we have to do to get back to that person, who they are? Well, it's not diagnosing them incorrectly, to your question, right? And a lot of what I saw was a lot of misdiagnosis. And you know, I read and study and work with Araz Tafik and Mary Lawrence and trying to see, like when Nourish started, how can we appropriately give them a diagnostic, you know, and not just psychologists, because psychologists are great at that too, but how can we really hit that problem, you know, like give them an appropriate diagnosis? Because what happens when you break your ankle in a car crash? What if a doctor tells you, hey, you tore a ligament and you actually have a broken bone? What happens when you find out, right, later that it's actually a broken bone? How relieving would that be? That's my example for everybody. Is like, how relieving is it to know what's actually wrong? You know, not here's these codes. You're depressed. Are you depressed because you drink, or you drink because you're depressed? Which one is it? We don't know, but let's figure it out. The chicken or the egg?
Was that commercially driven, or was that more sort of driven out of truly wanting to help people? I mean, so we know that sometimes it's easier to make a broad diagnosis than it is to actually dig in and try to figure out what's going on, right? Sure. So obviously this comes from a place of caring, I assume, right?
Absolutely.
But is there also sort of a commercial angle to this, which is like putting people on the right path and then utilizing their benefits more effectively?
Yeah, I think, of course. I think we're lying if we're saying you don't have to run a business. Like, how are you going to run the business if it's not effective? Right. And I think, you know, but at the bottom of my heart, like, you know, part of me could care less about, you know, any of that, right? The first and foremost thing in my mind, and you hear it when you talk to people, what's the first thing they talk about? We really want clients to have this and that and this. Or do they say, hey, you know what'll get you more off? Oh, but it will help the clients. What comes first when people speak to you, right? That's usually the thing that's most important to them, right? And like, I think for me, it was like, look, if I'm here to help people, let's help people and let's see how we can do it long term. And I've partnered with lots of people in the field, not just who I work with, right? Like, we're trying to solve problems. And I think, to your point, right, you solve the problem, the money will come. Yeah. And then more money will come to help you solve more problems and help more people. So it's just like, it's interesting how, I guess I hope that answers your question.
Well, I mean, what have you seen change as a result of shifting that approach?
Oh man, I mean, look, you know, people are getting better. I got to dig through our outcomes, like not through like the analytics on the EMR, but I actually did a collation of our own data since we opened. And I mean, you know, the MCID is what outcomes are based on. Payers love it, but I love it because what it showed is people are getting better. You know, risk was minimized by like 47% based on the suicide assessments, right? Like from start to their finish there. Like, people are getting better. So I can see it in data. Like, this is actual fact. Whatever the clinicians and the teams on the ground and all the group offerings, however we designed it, and it was a bunch of people. Like, it's just such an eclectic group of, hey, we should do this in every turn. You know, let's change this. Let's add physical therapy as an offering. Like, everything that has to do with nurturing the mind, body, spirit, you know, and the psychiatric diagnosis, like, people are getting better. Like the GAD-7s, the PHQ-9s, you know, like, it's phenomenal. I wish I had all the data on me, but it's great. Like, people are actually getting better. I was like, wow, it works.
Yeah. Do you have outcome studies that are published or anything that we could link to that we can share?
Actually, we're working with NATAP. We were talking about NATAP earlier, and I think Jamie Vink Lee was saying, I gotta go get her or whatever. She's coming, right? Right. I'm working with Annie Peters. Like, Paul at Northbound has the executive director team working with Annie Peters doing the FORCE outcomes. Okay. So everything through KIPU goes through FORCE. Now, I collated them myself, so no, they're not published, but they will be through FORCE. Okay. Yeah. So, which is cool. They'll go back and collate everything and get it correct, and it's gonna be cool. I'm really excited to see it, you know. And then I'm going to add things like the HUDAS and things that, you know, that actually measure well-being, the WBI well-being index. I'm going to start trying to add things like that, at least across the network if they'll let me, you know, because we're a big network. So, you know.
Cole, you used the term effective a few times when you're explaining, really passionate about it. What do you think, like, what does a truly effective mental health treatment program look like in practice?
Okay, so there's a lot of, this is a loaded question, but I'll just try to give a very simple answer. First and foremost, it has to be about the patient, right? And it sounds very like general, but no, it has to be about the patient. You know, you have to do value-based care, which is based on the patient's needs. And the reality of that is like third wave, right? Like the later than CBT methods, the DBT frameworks, the ACTs, like put that in your framework and you can really help people with personality disorders that are co-occurring. You know, that's a common problem. Just some people listening will know. It's like, oh man, this personality disorder. And then you have all the stigma attached to that. They're borderline, they're narcissistic. It's like, oh, are they really though? Like, come on. Like that's gotten very popular as much as trauma was a buzzword. Like, let's be serious. Like, but you can help that. DBT, transference focused psychotherapy. Like there are things you can do. Stop acting like there aren't things you can do to help those people in the population. So not to anyone in general, but I had to tell myself, like, you can do this. And you got the awesome clinicians that can. So third wave, kind of the framework. And really, if you're going to focus on the whole person, focus on the whole person. We got HP Mental Health. My buddy Dimitri Fuchs is a doctor in physical therapy. They, you know, partner with us for a chronic pain program where it's not based on medication. It's based on actual physical therapy and what happens to your body when you step the wrong way, you know? Why does it hurt? Is it internal? Is it, you know, the somatic piece? So effective clinicians, to answer the rest of that question, effective clinicians that are vetted, a good operations team, like techs that care. You know, you pay them well, and we were doing nursing 24/7. I tried to do it. I keep pushing always. You know, always have medical. You know, and there's a lot of pieces there that go into that too. Precision medication, like intervention, like when they're there, like they're there for a reason. Let's get them on the proper medication, and even using genocyte testing. Like, hey, look, we have a couple awesome NPs psych NPs that, you know, do some genocyte testing. What medication is going to really work, you know? Like, let's make this a formula that's effective and give them a launch pad and give them a chance and tell them that their broken leg is actually a torn ligament, you know?
Do you find that the operations team kind of rolls with that, or do you actually have to shift their thinking as well?
You know what? I need to give a shout out to every tech and every nurse and every person on the ground in this field. They are the program. Yeah. You know, we can't act like we don't leave at 5 or, you know, I'm an executive. I mean, I'm working on strategy most of the time or dealing with direct reports or HR issues or past clients who call because of mental health. You're dealing with kind of some instability at times, right? And you're just trying to make it right. Like, let's be honest. Who is the program, right? Who is the program? They're the program. They set the tone. And as the, you know, your directors, your direct reports and everybody in charge, they set the culture. And yes, they can really buy in, you know, and they are the program, you know, and it's hard. Is it hard? Yeah, sure. But that's the job. You know, I always tell people that's the job, buddy. Like, you know, if you want to be in this field and you want to make a difference, that's the job. Get the buy-in, teach them, train them, tell them how to do this. You know, I implemented CPI across our whole network because there was no specific crisis training. So I went and got trained as a trainer and just did it. You know, on the C-suite, like allowed me to do it for everybody in our network. That's 300 people. So I got 115 trained out of, you know, all our brands. And so just a like example, you know, it's like, yeah, get them to buy in, help them though. You got to help them. I haven't, recently I'm passing down the residential reins to like my direct reports, and they're kind of taking a bigger role as I kind of move into some of this other stuff and building virtual bigger, which I haven't mentioned yet. I'll get to that. But, basically giving them like this platform to like implement change however they want. What do you think it needs? Like, why am I the guy? Like, you tell me what it needs. Usually that's the best answer, you know? Listening rather than talking, which I'm not always great at, but you know,
Well,
hey, look, I'm self-aware, you know?
I love it. I would love to just stay on this for just a second. I mean, you being a fixer, you know, what do you think is the biggest thing that's broken about the industry today that maybe you want to take on someday to fix, or that we as leaders in this industry should fix?
Man, there's a couple things that are tough, you know? The payer landscape, right? Like, how do we effectively partner with them to show them like this is necessary, you know? Like, and look, we're fighting the bad actor fight too in there too, right? Like, we're dealing with people who operate a certain way, and it's like, it's not my responsibility to try to, you know, change them. I can't, but I can try to make changes as the example, right? With how do you auth like, you know, like, how are you submitting? Like, are you doing the real work? Are you trying to partner with case managers when you go in network? Or even if you're not, like, do you have good people on your team who are really fighting for the clients, right? That's an issue, like a split issue you see. It's like the other people are like, yeah, just run it, you know, run it, get the auth. Like, you guys all know. And if you're listening, you know too. Like, there's that fight. And look, I think back to the original question, the one of the original questions, which is the business motivation. Of course, we got to make it run. We got to make the wheels roll, you know? But like, there has to be a dynamic balance, because if people are trying to talk, oh, the facilities did this, oh, marketing did this, there's always that fight. And if we could find a way, even with AI, to fix these fights, like, that's a unified front for these clients. That's a problem. Everyone has that problem. Like, and I know you guys know, I mean, if you've been around long enough, it's like, oh, the facilities are letting them ACA. Oh, the admissions team always tells me this, that, and the BD team, they need to get up their admin. Like, it's just like the eternal fight between those departments. Then you have clinical and operations. Like, they have their fights. Like, how do we unify everybody? What is that solution? Because that solution is the answer to real value-based care, at least in my mind. You know? I hope that answers it.
Yeah. No.
All right, so let's set aside the bad actor situation, because it's like there's not a whole lot we can do.
No, we can't.
But it's like, but recognize that they're out there, and recognize that gives all the rest of us a bad
100%.
name. I am curious though, in some of the data collection that you've done, do you have any experience in anything that has moved the needle with a payer, and any example that you could share?
Yeah, I think there's some very good you know, trainings that have taken place on UR by like actual UR nurses. Like, we've had you know, a consultant for a long time, and she comes and trains the clinical team on appropriate treatment planning, right? And I've seen it move the needle, and I've seen what Joint Commission is doing, and how DHCS, at least in our world, California, is following their footsteps, and they're looking at adding. Check this out, like GAD7, PHQ9, it's added like to the treatment plan now. And that what I think I'm seeing, I have to talk to some of my friends who are higher up in that fight, you know, is that creates more authorization and longer authorization, you know, and that has moved the needle, you know, actually training on what's important for the payers, right?
Well, so in your experience, what caused that to happen? Did the payers come say, hey, we want this, or was it more a matter of, hey, we can do this, and here's the difference that it makes? So like, who was the first mover?
I would say the payers we're always at their, you know,
yeah,
we're always at their mercy, it feels like. And at times, look, I'm not always in the UR meeting, right? Like, I mean, meaning like the RCM meeting, right? But when I get the information, I'm like, oh man, that could have been different, you know? And how that could have been different is following like this pattern, right? But I think, you know, what I have seen is alumni has moved the needle. Like alumni programs, and this is no secret. Like, there's a lot of like, even like some of those new applications. I mean, what is like InCircle? There's a couple other ones, but alumni programs have really moved the needle. And because it's interesting, there's a way that data connects, right? That data connects because you get longitudinal data, and payers want longitudinal data.
Right.
Tell me that your program...
They don't want a 30-day result. They don't want a 60-day result.
100%.
They want a 1, 2, 3 year result is what they want to see. Yeah.
And also those outcomes help you market. Like, if you hit your marketing team, right, there's this like... This is that unified front. Like, it's a wish and a hope at times, but you know, but man, like, wouldn't that be a beautiful world? everyone would get help, and then every department would be full, you know? So.
Yeah, I appreciate you sharing your recovery journey early on with us and the audience. And it's definitely a sign how passionate you are about this industry. But what do you think is maybe one misunderstanding about addiction that you wish more people knew about?
Oh, man. We can go really just down to, there's a couple, that's a loaded question, in saying like, what don't you understand about the brain chemistry, or what don't you understand about the people, right? And I think what happens is there may be, I said it earlier, I say this a lot, there's a person inside that person, you know? And this goes for all of society. Like, give them a chance. And look, they may have you know, done you wrong, et cetera, right? And I think, you know, the precision angle at family, you know, really can help this. And this goes for mental health patients too, but with addiction, like the stigma is still there. It's still alive. You know, even I've seen it with staff who get burnt out. They treat them like, you know, oh, this person's a junkie, whatever, you know? And oftentimes the language we use with other recovering people, like, you know, it concerns me. You know, and don't get me wrong, me and my boys and my buddies who got sober together, we're ridiculous with that, right? But in the ether, when you hear somebody speak about another addict, you know, an addict speak about another addict, someone in recovery, and it's just like, there is like a change in the language that could help that stigma, because people are going to perceive what they want to perceive, you know, and they're going to perceive what they think is right. I can't fault them for that, right? Like,
well, what I'm picking up on is I really love that there's a person in there, because the thing is, it's like there's the behavior that is a blinking red light, but that behavior, like, I mean, I'll just use you as an example, is like Cole's behavior is not Cole, right? And it's like Cole could be doing something right now that really aggravates the crap out of me. Cole could be doing something right now that's really abnormal, and that's really outside the realm of polite society. Okay.
Sure.
That is not who Cole is. And I have to remember that. And I think we all have to remember that, you know, we all have bad days, but it's like separate the behavior from the person.
Yeah. That's the basic like thing I would love to see happen, right? And how do you do that? Like, how do you actually like get the knowledge? It's like that you know, Todd Stumbo. I remember like out in Georgia, he was a Acadia CEO. He does a lot of things now, thoroughbred recovery, but he helped me out with like servant leadership when I first started. Like, he mentored me with servant leadership. Like, we were on the phone every Friday. He had me read The Servant, James Hunter, and like he taught me a lot. And one thing he did teach me too was that about perception, right? And it's like, and I do this when I do trainings. It's like, you know, you take the Roman numeral, like it's like, how do you turn that 6 to a 9? And it's like, it's really just the S next to the IX. It's not, oh, everyone tries to turn it over. Everyone tries to, you know, change the letter, or like, and it's really cool because that's that perception, you know? It's like, actually, some people, and you look around the room, everyone is thinking about things differently. If you don't take that into account, like, you're not going to have a stabilized solution for the problems we're trying to solve, essentially, you know? Like, individualize, you know, some of this stuff.
Yep.
At least to 5 categories, you know? You can't do everyone individually, but yeah.
Well, you talked about leading. Like, what have you learned about like leading people in this like really emotionally demanding industry?
Oh man, to lead is to serve. I mean, it's that simple. Like, you know, what I've always tried to do is that model. You know, it's always eclectic though, and like, I'm not perfect at it at all, and I think I'm happy about that. But you know, that we did like this leadership seminar, speaking of that, with all the managers, the directors recently, and I kind of like went laissez-faire on the assessment. So I ended up being like that laissez-faire, like hands-off type leader, right? And it's like that sometimes, but I'm always in service, right? So what can I do for my staff? What can they do for their staff? Like, how can we be of service? And I think what I have learned is I've made a lot of mistakes, a lot of imposter syndrome, a lot of learning about how you don't, operate in a situation where fear is the main motivator. You don't push fear onto your staff, like, because it can happen, you know? like where you get authoritative because you feel ego come in there and you really want them to do what you want them to do, but there is ironically an easier, softer way at times, right? Like who is that person? Like leadership is so individualized. Like you can call it what you want, but that eclectic mix is necessary. Who are you leading? That depends on that day, right?
Yeah.
And how do they respond? It's all about language. It really is. Like what is their learning style, language style? It's really such a, it's a fun thing to do though. And it's really like, it's rewarding, and I've been taught a lot, and I learn something new every day. Basically what I know is you really just hire people that are smarter than you, so you don't tell them what to do, they tell you what to do. That's leadership. Like, man, I'm telling you, like if you're gonna hire smart people and really effective, competent people, don't go telling them what to do. You hired them because they're good at something. Let them tell you what to do. It's really simple.
All right, so Cole, what was the last thing that you learned from one of those smart people that you hired?
The last thing. Oh, well, it's not from the smart people that it's a situation involving them. Like when I'm transitioning kind of out of res and putting them in, and this is it goes back, but I was telling Jillian about this the other day. I was like, to be honest, clarity is kindness is like my favorite phrase.
Yeah, clear as kind.
Yeah,
clear as
kind. She always says that. And it wasn't just her probably, like who knows, but she's the one who got it locked in my head like years ago, like before I ever worked with her. And yeah, man, to be clear is to be kind, and like I learn it again every day. Like every time I'm in an interaction with one of my direct reports or, one of the team, and like, oh man, because you guys know by now, like I can talk about anything for any period of time, but to be clear is to be kind, right?
Yeah.
And if you want them to be successful, you got to give them the tools and the clear structure to be successful,
Yeah, well, it sounds like you surround yourself with a great team, and that's very important to you. Like, what kind of qualities are you looking for in the people that you surround yourself with?
Loyalty, but not false loyalty, Like, I don't subscribe to we're a family thing, like, because what happens is people get too loyal, and they fail to tell you what's wrong, So that's a big one for me is loyalty, but not false loyalty, right? Integrity, of course, right? Integrity. And I think these days, man, you can be kind, And I look for people that are kind, rough around the edges and still kind, right? And I think I surround myself with people that are kind because I've had a rough enough time with life. I think a lot of us have. We all got our backgrounds and our things. It's like, I don't need a bunch of barking dogs around me, I want kind. They can be a big dog or a scary person looking, right, or whatever the stigma about them may be. But yeah, I look for people that are kind. I do because it's really free. It's free to be kind, and it really gets you further than anything else does, right? Like you could be the biggest, the biggest awesomest person ever, but if you're not kind, I don't know, like yeah man, kind and I love people that are, practice humility even when they are genius, right? Like, because you're like, oh, wow, you actually are genius. You're humble.
Yep.
So,
Absolutely.
So yeah, those things are pretty much it. I would say.
What's the first thing you do to help, or like, what do you teach your team is the most important thing about building trust real quick with a family that's looking for treatment?
Oh man, so the the key thing about building trust with a family, right? Like, if they're in an open conflict, right? You are not the mediator. You are, the listening, function, right? And if they ask you for feedback, there's that intervention styles that come in there for me, because I remember doing a RISE training here probably like 9 years ago.
Yeah.
I never finished it, but never finished the hours, but Judith is great,
Yep.
That invitational intervention style, honestly, it's mixed with a couple other styles, but that's family systems, obviously the DMFT, like systemic looks at their family. You have no idea what systems are functioning within those other systems in their family. So take a step back, listen and listen, and then when prompted, be ready to inject that intervention, put them on a path to heal, people don't want to hear, and they want clarity, right? Clarity is kindness.
Mm-hmm.
So they want that, even if it's a problem that you can diagnose. It doesn't have to be the diagnosis. Like, the diagnostic's important. Like, what's the problem here? So I think getting in there and understanding that and then giving them a solution and a path forward is pretty effective.
All right, so let's shift to kind of what we were rapping about before the podcast. Okay, so there's a reason you came to Nashville aside from being a great hang. I mean, Nashville's a great hang.
It really is.
That being said, so the AI conference is taking place out there. So your curious brain is probably going in overdrive, thinking about AI tools and innovation that's happening in our space. Going to give you the wide field here. Where do you want to start that conversation in terms of where your energy's going?
Okay, so first and foremost, for like my role, they just gave me the honor of working with the implementation specialist. They call it AI champion, but basically just means it's not in the title. It's just I'm championing the AI integration into the Northbound treatment network, which is gigantic, right? 160 beds, 300 staff, or 200.
So were you anointed AI champion?
Yeah, basically. It was Paul and Jillian. We discussed it, and it was really just part of that. And it was probably because over the past couple of years I've been interested, and I've been building tools and doing things like that and having a lot of fun, trying to solve problems.
All right. Well, I realize I gave you the feel, but I just want to steer for just 1 second. Okay.
Yeah, please do. Yeah.
In that role as AI champion, because I think a lot of people listening this is going to resonate.
Okay.
How much of that is explaining to people what's possible as opposed to you developing and implementing and just saying, hey guys, here's what we're going to do? How much of it is teaching, explaining?
Oh man. So
whiteboarding.
Wow. I think we're just getting started at the network, and we brought in a team called Tandem, and they're going to essentially, it starts with literally like aligning, like offsite aligning, like doing offsite, togetherness kind of thing. Like, so we're all aligned on it. That's how the CEO kind of set it up. And so we will see, right? But in my, prediction and from what the people I've talked to about what I'm seeing and hearing, at least, is a lot of it is training. And so the tools that they're training on, the hope is that there's an actual ROI, right? Then there's the convincing, you're going to have to do some convincing, The implementation specialists we use are doing some assessments where they collate the data with a whole team. We just put them out to it's a big network. And I think with us, that's it's staged for the human element. And I think it's important. And I think it's going to really give everyone a chance to have a voice about the AI implementation. Now, if you talk about me, just my interest in it, I think it's bullish, I'm very
So, but where within the organization, where did you choose to start? And then
it's with the implementation specialist, I think, and I think.
So, but what part of the business though was it on the clinical side?
We don't know yet. That's where we're at.
Okay.
Yeah.
Right. So, okay, got it. So still early days.
Yeah,
okay.
Yeah.
So you're way more advanced at this point than the organization is, right?
Sure. Like in developer stuff and things like I do. Yeah, I started as a hobby. Me and my brother, he taught me a lot, and then I started working with some guys that I knew, not working, but they were just, giving me advice, because you just start to learn, and it's I'm curious, like you said. So I started building some tools based on some needs we had, right? Just to see if I could do it, and this was a while ago. This is before kind of the Claude Code launched pretty hard and things like that. And then as the AI has gotten more advanced, I've been able to use the functionality for real-time problems, we talked about, those tools, the compliance tool, compliance IQ, things like that. Also with the psychosis stuff, I didn't show you guys that though, psychosis safety protocol. I had the doc, this is peer reviewed too. This manual that I told you I did on my doctoral project is peer reviewed by psychiatrists, 2 psych NPs, a clinical director, and 3 psych NPs, and LCSW, 2 LCSWs. And so what I did was I took that and I built a learning management system, which is a full-on tiered training for the psychosis safety protocol, right? And I'm talking you can implement this at all the way to the hospital enterprise level, like a CPI, but it is specifically based on psychosis, because what happens with the stigma there? So in that, I've been able to learn how to code a learning management system so I could build it myself and not spend $100,000 to do so, right? Like things like that, solving problems for me so I can solve problems for people, right? And that's been so rewarding, you know? I wanted to take it to that side too, but yeah, I mean, look, building tools that help us with compliance, building tools that, you know.
So how difficult was it for you to kind of bridge the gap from your knowledge base to becoming a full-on developer?
Oh man, I don't know when it happened. To be honest, I just go. My wife's like, "You're still doing that?" Like, you know, God bless her. You know, because I have a. It's great for me because.
So I mean, you're what everyone would call a vibe coder, right?
At first, yeah. Now it just became like, hey, this is what I want, and I'm gonna use this, and this. How do we do it? Oh no, you can't do that. You have to do this. I'll call a friend. Like, what do we do here? Call my brother. Like, actually. Not taking, because vibe coding's, it's cool. Like that's what a lot of people do, and that's how you get your base, right? But I think it goes so far now that it's like AI is so not perfect. It's just like when people put writing in ChatGPT. How many times do you correct it? You know?
Yeah.
Imagine doing that for hundreds of hours, you know? And it just is so rewarding and fun. And then we get to do all the branding and marketing because my wife's a genius with that brand development. So basically business in a box, you know, and solving problems. So it's been really cool, man. I mean, I showed you guys the crush tool.
It's very, very impressive. I mean, you know, you talk at the tip of the spear for like being a doctor, being a leader, you know, just with your innovation that you're doing with AI champion. I guess, you know, talking about like most treatment programs are going, hey, we need an AI champion. Mm-hmm. And what I see the common mistake is that they typically go to the IT person or, you know, they, you know, whoever that's handling technology for them, and that's the person because they want to control everything.
That makes sense.
And I don't know that that's always the right way to go. And in your case, I mean, the AI champion's a doctor that's, you know, data, like you're also,
like that, huh?
you know, very data driven.
Well, I mean, it's super interesting because, I mean, to pick up on what Mark's saying, super interesting because, is it because everyone in the organization knows Cole and it's like Cole is right, or is is Cole in the right role for this? What do you think that is?
When I talked to the CEO and COO, like at the time we were just in the executive leadership meeting. And they're just like, hey, we need, you know, CEO's like, we need an AI champion because he's up on the, you know, he's an ATAP board member. He's up on the industry, right? And he knows like this is a duplicate work. It's costing money, and you know, this can help with all these problems. And he's probably talking to his friends in the field, and you know, they just know I'm pretty good with the AI at the time, so they don't know the extent. And I don't expect to be doing that programming inside of the company like that. It's really just someone who understands it. I think probably that's where it landed. Someone who understands it enough to like, you know, be able to explain in between like a developer and like the ground, right? Or also on top of that, they probably just knew that like, you know, I had built Nourish and like things were really kind of like not cruising. It's never cruising, but you know what I mean? It got to the point where it's sustainable and it's like, hey, look, he'll have some, you know, probably have some time to put in this area while he's doing the virtual care more and building those brands. So it was probably a combination of things, but I think, you know, if they were to say why, I don't know if it was anything but like, hey, look, you have the space, you know a little bit about it. It wasn't, they didn't say, oh, you have all these apps or you've done this. They didn't really know that.
They didn't really know you did. No. You were already doing that, right?
I was already doing that.
Our advice to clients is always the person that's very passionate about it, but they're also intellectually curious about learning new stuff because it changes each and every day. You know it better than anybody. I mean, the stuff you're working on, I mean, you almost could talk at the tip of the spear on AI development too, and it's not your primary focus, but now it is, being the champion. But you know, I guess with all this, like, what are you the most excited about that's happening in the industry? Where do you see us being in the next couple years?
Oh, man. Well, what I do see is that people are smart. Okay, the smart people are getting a chance to shine a little bit right now, which is cool. And like, you don't always see that in this world, you know, the old school BD, like, you know, that they end up being CEOs or, you know, they end up being the owners, which is great. Look, a lot of those guys are my friends and and I appreciate their hustle and, you know, their grind. I think right now some of the smart people are getting to shine. It's kind of cool to watch, you know. You see the CCO, the chief clinical officers, they're the ones kind of in the spotlight. Yeah. And they don't always know, and I'm not talking about anybody in particular, and I don't mean to generalize, so it's no offense to anybody, but they don't particularly know how to do that type of, you know, whether it's executive work, whether it's speaking, talks, you know, dealing with such high-level people and implementation with egos, and you know how it goes on the high-level stuff too. And I think it's cool to see them kind of shine. You know, and to see other people come from out of our space to see our space and be like, whoa, these people are a little bit different than you think. Like, they're not just average, like, because they think they're going to come in here and sell this new software. And it's like, bro, like, you're dealing with some pretty kind of like, you know, straight up people. I mean, you know.
Well, the amount of outside investment that is coming into this space, assuming that they can take over this space as a result of AI implementations or things like that. What is your take? I have a take, but what is your take on, like, what are they experiencing?
I would say it's probably a tough sell to certain people, and I look, I don't speak about anybody negatively, like, in saying this, but I think, you know, it's just that world where they're trying to get the startup, you know, the startup guys are coming in and the private equity guys are behind them. They're like, hey, we could really, you know, turn and burn. We could, you know, get this implementation going. I've experienced it and seen it already. And it's like, look, hey, that's your hustle, that's your game, great. But I don't think it's going to work here. And I think that's why we brought in the, you know, the team we did. And I see a lot of people doing that because there's the human side.
Right.
Like, good luck. You know, that's what I'll say. I'll say, good luck. You know, this could be very dangerous if you're not taking that into account. That's all. Because we're dealing with clients, man. These are the most, like, sensitive and, you know, like, potentially dangerous topics, not topics, but information if it's handled in the wrong way. Like, so many bad things could happen if they do that too quickly, I guess, you know, I think that's probably what they're going to experience is people going, yeah, sure, come on. And then it's going to blow up, you know, or people going like, hey, hold on, you know, that's probably what, if I could put it into an action, they'd be like, ho, pump the brakes, buddy. Let's temper this. And I've seen it in our organization, but it was for a good reason, you know, and then I saw it, I was like, that makes sense, you know, so that's probably what they're experiencing. I would imagine, you know. Unless, what's your take? Sorry, I bet you have a good one.
I mean, my take is that the MBA playbook is like, this is an obvious industry to focus because, I mean, it you know, it's still feels not super consolidated. It feels like there's room for innovation. It feels like there's some processes that need to be upscaled. Now, that's the MBA view of it. Okay, but once people start the individual conversations and then understanding the use cases, I think they're going to run into a use case skepticism that within our industry, we're just naturally sort of a skeptical people because, I mean, look at the lived experience. The lived experience is going to be, it's like, hold on. It's like, we're used to people from the outside telling us this great stuff that we need to go try. Right?
That was a good one. I got it. Yeah. I got it.
And so it's kind of like, well,
that's sharp. I get that. Yeah, that's a good point. And here's the other part. Like, when I'm coding a tool for a clinician, I'm a clinician. You know, what I see is like a bunch of people who aren't clinicians trying to make these things, and you know, and I spoke with this wonderful lady who found me on LinkedIn the other day, and like, I know we probably were running out of time, but she was great. She just reached out to me because she became a therapist, but came from tech product for 15 years. She still does it. She just wanted to talk to me about like what we do, and we just chopped it up. And she told me all about tech and product, and then she told me that there's people trying to do things like Deba Kai is her name. Give her a shout out. But she was telling me like she ran across like demos for agentic EMDR. Like, and she's just like, whoa. Yes, right? But you see, like, this is their brain, but you know, you're going to hire the world's foremost clinician, and you know what? You're going to get their brain. Well, that's not quite how that's going to go, buddy. Like, and so we
have 90 hours of Francine Shapiro talking about EMDR. We have 90 hours of, and it's like, and we've created an agentic EMDR based off videos from Francine Shapiro. And so, it is like, hold on.
It's so, to your guys' point, it's interesting. We talked about this earlier. Like, I'm a clinician who codes, right? You know, I'm not a clinician these days, right? I'm not really in practice, more like, operator turned strategist or whatever, what have you. And, but I'm a clinician at my base, the years of clinical work, LADAC, licensed advanced alcohol and drug counselor, doctor of marriage and family therapy, CEAP too. I got a couple other ones somewhere down there. And, when I'm looking at this, I'm like, is this even going to work? Like as a clinician too, like that, I get to tune into that brain as an operator, strategist, and clinician and say like, oh, wow, is this even going to work?
Right.
Even with my admissions side, dealing with admissions teams my whole career and BD guys, like I can talk to them and be like, what do you think? Some of the tools I built, I got the director of admissions just to help me out. Just like, hey, you like this? And it's not like I'm building it for anything, but I'll bring it in sometimes after spending all night and then be like, hey, check this out. But it's someone who does it inside who really can see it.
Exactly. And so I think one of the key takeaways for anybody who's listening about wanting to be an AI champion within, either for yourself or for your organization, you've got to be curious and you've got to work on these tools and you got to build these tools, but you need a bunch of people on speed dial.
You do.
You need a bunch of people on speed dial where you can be like, I need to phone a friend and I need to, it's like, am I on the right track here? What do you think? What's going on here? And it's part of that is because it's happening so fast, but then part of it is also there are use cases we don't even know about yet, right? That are going to start appearing.
They are. Yeah.
So I mean,
we data sensitive, right?
Right.
That's the other part.
And
you're just getting crazy.
Exactly. And so, I mean, we love the idea of, building a network, building a community where people are trying to advance their craft, but then also advance the industry so that we're all doing this together. Yeah. And then eventually it's like, you know what? I mean, the bad operators, they're going to weed themselves out.
Always some way, somehow, right?
Some way, somehow. Yeah.
Cole, Jeff, and I, we expected a lot on today's show, and you delivered even more. So thank you very much.
Thank you guys for having me.
This was a great episode. Yeah. So we'll go ahead and wrap it up. That's a wrap for today's episode. On behalf of Jeff, myself, and the entire MasterMined crew, thank you for tuning in today. If this conversation with Cole sparked any interest, it was great to hear that you allow people to reach out to you. We'll put your information in the show notes, and people can reach out to you. If you have any questions for us, please drop them in the show notes as well, and we'll reach back out to you with the answers. Also, if you would, rate, review, and subscribe, most importantly, to these channels so that we can get our message out to even more people. Until next time, we'll see you on MasterMined.
That wraps up this episode of MasterMined. Thank you so much for joining us. And remember, MasterMined is not just a podcast, it's a community. So don't forget to comment, subscribe, and review us. Your feedback helps us continue to bring you content that's relevant and relatable. Thanks again to our sponsor, Snapshot, a digital media marketing agency. And thank you for joining us on MasterMined, your behavioral health playbook.